The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is our third week talking with Dr. Camille Fung about neonatal opioid withdrawal syndrome. And this has just been fascinating. And again, I've been doing this for a few years, and this is not a new problem. It's a bigger problem than it was when I first started. But I think this is just such a fundamental rethinking of how to treat this issue. And I just think this has been great. Before we start, Camille, do you have any disclosures?
I have not developed any new disclosures.
Okay. For those of you who have conflicts for Dr. Fung, please send those to conflictsfordrfung.com, and we'll do what we can. Let's talk about some of the fundamentals about substance exposure. First of all, one of the things we do a lot of the time is testing to see, looking at exposures. I want to sort of talk about two things here. One is, how do the tests work and what are their limitations? And then my second question, I want you to be anticipating this because I don't think this is in the outline, is what's our rationale for testing? You know, if we have a good history, what's our rationale? So let's start with this. I think we're all familiar with the issues of urine, meconium, and cord segment tissue. What are the advantages and disadvantages of urine?
Yeah. I think in adult medicine, urine drug testing is probably the gold standard. And so that may be, how it creeps down to the neonates. But I would say urine drug testing in a baby with substance exposure is actually very limited because it really reflects on what the mother has used in the last 72 hours at best. And sometimes people will say it's great if she can get like the first urine because it's most concentrated, but it's not a great test because it just doesn't reflect the long-term exposure. It's really good for the last 72 hours. And if the mom hasn't used anything in the last 72 hours, you may miss the exposure. So that's why we've gotten away from urine testing in babies.
And if she had never used anything before the last 72 hours, the baby's probably not going to be withdrawing.
Yeah, I mean, a study in the 1960 from the AAP said if you haven't had anything in a week, you're probably safe. But again, I think it just depends on when the substance was used. And having a negative urine drug screen, sometimes just know that may not be 100% reassuring. Yeah, so not using urine, what do we do? So historically, meconium, the baby's first stool, what has been used to test. But again, that has some nuances too, right? So meconium reflects exposure from about 20 weeks on, and every baby should pass meconium. However, sometimes our neonates, our preemies, they may have a delayed passage of meconium. And sometimes we may give them something postnatally to manage whatever it is that they're managing. So it complicates the picture a little bit if you have prenatal exposure and then some postnatal exposure, which is why we've now been reserved to using cord toxicology screen because that actually reflects exposure from 12 weeks on. And every baby, again, should have an umbilical cord. And so that is really the gold standard now. And fortunately for us in Salt Lake City, ARUP is the laboratory who does a lot of the cord testing. Other parts of the country, sometimes they send it to ARUP. They send it to some of the laboratories that are closer. But not every lab does cord tox testing.
One other question I have here about limitations. So for one thing, trying to get a first urine is challenging at best. And being in a hospital where we test for CMV, we often replace several bags before we actually get any urine. So we've obviously missed that first void. The other thing is, my understanding is that fentanyl from an epidural anesthetic may show up in that urine screen. And so it's hard to know how helpful that is to know if we're looking for fentanyl.
Yeah, totally. I think it could actually show up in all three of the toxicology screens. And so you just have to make sure you have that fentanyl documented in labor and delivery. If it shows up in your toxicology screen, the mother tells you that she's never used fentanyl.
So what's the purpose of the screen? Is the purpose of the screen to find out things that may not have come up in the history? Is it including polysubstance exposure? Why am I testing?
Yeah, absolutely. That's exactly what it is, to anticipate things that have not been actually reported in the medical records. And also, I think from a treatment standpoint, it's important to know, because if you didn't know a substance was there and it was not documented, and you just keep trying to treat it with one thing and it's not working, having that delineated, having the toxicology screen there may help you figure out what other treatment may be needed.
Are there situations where you do testing where the parent may deny all exposures, but you say this is a situation that calls for a test?
Yeah, and it's actually very state dependent whether you need consent to send a toxicology screen on an infant. And I always have full disclosure. I always tell the family that I'm sending a toxicology screen from the baby. If there's been no documentation of any exposure and the baby is having symptoms consistent with withdrawal, that's when I typically go back to the parents and say, I'm seeing these things. It's concerning for a withdrawal syndrome,
Mhm.
and there's no documentation of it in your chart. So I need to do it in order to know how to help your baby. And I kind of think of it that way. And full disclosure, I think is always important for these families, because again, they may not be telling you because of past experiences.
Sure, framing questions. I was thinking about, self-editing because some of the language that we use, I think, exposes the fact that we do find ourselves in difficult situations. For instance, I was thinking of the term guilt by association, where really guilt should be less of the issue here than how do we help with healing. I don't want to sound completely naive, but I think that we have to start from a foundation of at least the expectation that we want to do what we can to help everyone in this orbit.
Yeah, absolutely. I really think that's important, is just, again, going back to the first episode, is be compassionate, be non-judgmental, just be open and tell them why you're doing what you're doing. I think that goes a long way.
So what else should we be doing? I mean, obviously, I think once we found something that enables us to help provide better treatment for the infant,
Mhm.
guessing this is also where we should look at social work involvement and that sort of thing.
Absolutely. I think social work has to be involved in cases where babies have NOWS. And for a whole host of reasons, right? Does the mom need mental health referral? Does the mother need actually an addiction specialist to help her now that she's delivered? Is the home environment safe? You
Mhm.
might actually need to just look at, after discharge, what does the home situation look like? Really, what resources that the family continues to need or may have new needs, so that you make a successful environment for that baby to come home to. And unfortunately, it's emotionally charged oftentimes with these families, and they may be, even DCFS cases pending, or you're now having a report because of what you find in the toxicology screens, and it could take time for a lot of these things to occur. Court cases, if you ever even have to go to court, takes a while. So the baby may be medically ready for discharge, but just can't go because of, a pending DCFS case, for example. So it's important to involve social. I always call social work the moment I have a baby with substance exposure.
Sure. And, it's interesting because, again, I think the way we look at this colors what we're able to do. But I think thinking of this as a chronic disease, and, I don't think we would take as punitive approach for someone who has a different chronic disease. Are you able to take care of this infant?
Absolutely. And a lot of mothers with opioid use have concurrent mental health illnesses, right? So they could have depression, bipolar disorder, anxiety disorder. So a lot of these things actually may surface because now you have a really stressful environment post delivery. And so I think that definitely needs to be addressed. I don't know how many moms I've sent to Dr. Marcella Smith that I talked to earlier about, if they were not in a substance use disorder clinic. She takes everybody. I mean, this woman is incredible. And so I don't know how many, the mothers may not show up, but at least,
For sure.
the referrals are made. I talk to her, I call her, I said, I have another mommy for you. Can you please help her? And she always takes them.
Amazing. Let's talk about discharge planning. So last week we talked about the fact that having a clear landing spot for the baby is vital. You're not going to be able to follow up with a pediatrician or their pediatric care provider in the next 2 days if you haven't identified who that is. So if it's not me discharging the baby to me, then I should probably at least be communicating with who that person is going to follow up with.
Yeah, so I think the pediatric follow-up is important, but it also things that can be done in the home front too, right? So having a home visitation nurse, if you feel like that mom needs actually have a visit from a nurse to the home to just kind of make sure things are going okay, that's definitely something we should look into. And all babies with NOWS are, like I said, at risk for developmental delay. So early intervention, they all should be referred to early intervention programs. So again, that's somebody coming to the home. So the more you can do kind of in the home environment, I think helps. But definitely you need somebody to orchestrate all of this. So I think having a pediatrician to make sure a lot of these things are happening, it's important.
In the very, very short term, knowing that we know that eat, sleep, console helps, some reinforcement of that with families, it seems it would go a long way.
Yeah, like I mentioned in the second episode, the long-term follow-up, that study, the data will be published soon, I hope, to know what it looks like for those babies. And hopefully the survey results will also come out for family interactions to make sure that the eat, sleep, console isn't doing harm compared to the Finnegan score. So stay tuned is what I would say. But I really think that the country is going to go towards using ESC as the gold standard of care.
What sorts of things do we see in kids as they grow up after exposures in utero?
Yeah, so I think we talked about developmental delays. That's one, that they are at higher risk. And even things that are subtle, right? It's not just they have grossly cognitive issues. Sometimes it could be ADHD, sometimes it could be some learning disability. So that's why I think early intervention is important. Head Start is also important in the school environment. So that's a big piece. And then in terms of like their feeding and growth, I would say that's usually not a huge piece. A lot of babies will continue to keep a close eye on them. They should be able to continue to grow and thrive. I don't know of any studies where they say that, these babies have any particular growth and feeding issues. Sometimes, though, they may be small for gestational age at birth just because a lot of mothers may not have taken good care of themselves or they have malnutrition to start with, and they may even have placental insufficiency. So those babies may be small at birth and they may continue to be a little bit smaller, but hopefully there will be some degree of catch up growth that occurs. And yeah, a lot of it is mostly developmental, is what you have to be worried about. And I would say, even in the adolescent age, babies who have been exposed to substances in utero may have higher risk of their own addiction and substance use disorder.
Do we know if that's physiologic or if that's environmental?
I think there are, epigenetic changes that occur at the either metabolism or receptor level. So I do wonder if there's some of that has happened. That's why they're at higher risk.
That's so interesting. And again, I think we put a lot of emphasis on how do we get these kids safely from being born into infancy. The other huge, 999 pieces of the 1,000-piece puzzle are how do we support this family then in nurturing, a great human being?
Yeah, I know, the eSleep Console is trying to arm families with the kind of the ability to help. But sometimes I also remind people that some of these parents may not have been properly parented when they were children, because if there is any intergenerational substance use disorder. So I think it's just a bigger problem than we think. It's not just one baby with NOWS, it's carried around a whole lot of other environmental issues that probably need to be addressed, on an ongoing basis.
Yeah. And one of the real beautiful things I think about continuity care in pediatrics is this ability to be a safety net at all the junctures, at all the developmental steps. And, hats off to the people who do that so well. I'm impressed. Camille, anything else we should be thinking about with these kids?
I think one thing to remember is that we can never predict the severity of withdrawal. I think, like I mentioned before, I always go in thinking that every baby's going to have severe withdrawal. And if they don't, that's awesome.
Yeah.
um, just go in thinking maybe, I don't know, if a worst case scenario, and if they turn out in a better scenario, then I love that. And just be non-judgmental would be the other big piece. I would
Yeah.
add.
And just a reiteration of a question I think I asked last week, but I'm still mulling it over. If a baby does not withdraw after being at risk for withdrawal, when do I feel relatively safe sending the baby home with the understanding that I'm going to see this baby back, the next day, 2 days at most? But at what point, I don't think these are great candidates for 24-hour discharge. What is a safe interval?
Yeah, so again, it goes back to what the substances were. So for short-acting opioids, we typically think that they're going to withdraw within 24 to 48 hours, right? Versus if you are exposed to the longer-acting methadone, buprenorphine, it could take up to 72, sometimes 96 hours before a baby with withdrawal. So I would kind of, again, look at the exposures to try to figure out when is it safe. If the baby never shown any symptoms with the short-acting, yeah, I think it's time to go, right? But if you are worried in any way that they may not have presented symptoms and you on a long acting, the baby looks fine, have that follow up then the next day or two
Yeah,
to
yeah,
kind
yeah.
of try to capture that later withdrawal. I mean, sometimes it may be up to a week before a baby withdraws, but that's the rare scenario, right?
But as with everything else, you arm yourself with as much information as possible. You use the best judgment that you can, and you
Mhm.
hope for the best.
Yeah.
But you cushion all that by staying in touch.
Absolutely. Absolutely. You just tell the mom, we can have this planned visit. But if something happens in 12 hours,
Mhm.
please call the clinic, come to the emergency department, whatever it is that you got to tell the mother that we're not completely out of the woods. You're discharging today because the baby's doing fine, but they may still be issues that you just need to reach out if the planned visit hasn't happened yet.
Because it's all about being smart and compassionate, right?
Yes, yes. And just sometimes, more education. I feel like education is always good.
Right, right. Well, Camille, this has just been fascinating. Thank you so much for indulging me and indulging us and take some time to talk about this month. I hope you're willing to come back next week to answer some questions. And as always, please send your questions to questions@vcurb.com and like and subscribe because, that's what you do with podcasts. And thanks to Elisa Stoddard for making this sound like a podcast. And thanks to Janice for listening. We'll see you next week.
Thank you.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Wirkus, who also composed the theme music. See you next time.